Mat and transfer skills post-spinal cord injury. This is a small module section in EHYT 6366 Bridge Neurotherapeutics 2 Spinal Cord Injury at University of Texas Medical Branch, School of Health Professions Physical Therapy Department. Primary instructor Adriana Lapria, PT, DPT, GCS, CEAA. Clinical instructor Jamie Boudreau, PT, DPT, and TS. Objectives. By the end of this module, the student of physical therapy will be able to analyze and demonstrate the mat and transfer skills techniques appropriate for patients with different spinal cord injury levels, including sit pivot transfers, supine to from prone, prone on elbows, long sitting, transferring in long sitting, wheelchair to and from floor transitions. Mat and transfer skills abilities in individuals' status post spinal cord injury depend on body type, body weight, level of injury, type of injury, any type of impairments such as pain, joint contractures, or spasticity that may interfere with the functional task. Environment such as the surface height or firmness. We will go over the functional mat wheelchair skills as sit pivot transfers, supine to from prone, prone on elbows, long sitting, transferring in long sitting, wheelchair to from floor transitions. First, let's look at sit pivot transfers. Sit pivot transfers have been defined and divided the three different phases by Perry et al. Perry et al. Look at the activation that muscle activation that patients with complete spinal cord injury have above the level of injury. These phases are preparation phase, lifting phase, descending phase. Preparation phase was basically set up for the patient to be able to perform the sit pivot transfer. What happens before the lifting phase? The lifting phase is defined by the bottom coming up from the surface they're sitting on. And the descending phase is just basically lowering your body back to the surface and completing the transfer.
If they have a level injury that is above C8, then you have to make sure throughout all of this that they keep their fingers in a flexed position, maintain that tension in the flexor tendons, because the flexor tendons is going to, or that tightness in the flexor tendons is grasp where they can functionally use their contractures to grasp things such as the spinal cord itself. So the direction in which the hips are going to be moving, we instruct the patient to forcefully move their head down into the opposite direction. And so the down is so that whenever the patient moves their head down, we use the tightness that they've developed in the low back and in their throughout their pelvis to pull their trunk forward and hopefully offload their bottom. And then the directional component is to, just like she showed you, as she rotated to the right, her hips would then be pulled to the left, where she turned her head. So if a patient needs to scoot to the right, again, we would teach them to load by having their head back and to the right, and then throwing their head down and to the left. All the lift that they need just by throwing their head down. They're not going to be able to offload the bottom enough to be able to scoot like that. So what you also have to do is first just teach them the head-hip relationships, but then teach them how to time when they throw their head down. So if she's going to scoot to the left, she would throw her head, again, she would look to the left and look up, and then she would throw her head down to the right. But as she's doing that, she's pushing down through her arms, whether it's using her lats with the extended elbows and using her anterior delts as well to help elevate her upper body and offload her bottom even more. To go in with either a sheet underneath the patient, or go in and just manually facilitate at the hips and have them get out. Make sure your head is out of the way because they're going to be thrusting, and so it actually would be up here. So what I would do is have her practice the thrust and help her scoop just a little bit at a time. She's obviously well-bodied, she's intact neurologically, and so she can scoot, but initially the scoots are going to be in small increments, back and forth, left and right.
In conclusion, when a patient is unable to transfer from the wheelchair or one surface to another surface as the mat or the hospital bed, a way to minimize this inability to do it independently, patients can use a slide board, as you may know. When transferring from the mat to the chair using a slide board, you have different also phases that need to be mastered by the patient or the patient's caregiver. These include placement of the slide board, basically the body displaying over the slide board safely, and taking the slide board off. Remember that there are certain degrees that must take place, and the head-to-hip relationship still applies.
The first thing about a sliding board, it becomes positioning it, pre-positioning it, which you can see she's already well versed in. But what you want to do is take the end of the board, and just like she's using her tenodesis grasp, she's clasping her finger. If they don't have holes, and you can actually use the edge of the board, depending on the length of the board. The other variation that you might see is not just a horizontal hole, but a vertical hole as well. And so some patients prefer that because they can get more force with their horizontal adductors have intact. Some of them can use their biceps and with a vertical hold and pull them in better. So your sliding boards will vary. But again, pre-positioning, you take the end and you want to take it and bring it towards the sacrum, basically towards the opposite, on her opposite arm, and positioned it in herself. Again, initially this is something that therapists may have to do themselves. May even need a second pair of hands to support the patient as they offload one side and help them with pre-positioning. So to initiate the transfer, the patient's going to basically do the exact same scoot as before, where they are going to scoot to their left. So they're going to have to elevate their head and look to the left, and then throw their head down and to the right while they depress their shoulders and scoot their bottom towards the left. Repositioning of the hands for every scoot. So this may require several different scoots. While some patients may get stronger and more coordinated to the point that they only need one scoot or one thrust to be able to do the entire transfer. Initially, you should expect to get from one surface to the other. Again, initially, it may also require some assistance in helping them get that scoot down. Just like she showed you, in order to get the sliding board out, she first hooked one arm back of the chair, which she transferred to, and then to enable her to pull over and offload her right hip. That way she could then grasp the sliding board and pull it out from underneath her body.
So head and head and head to the other side. There you go. Can you bring your arm out to here like this? There you go. And then it's going to go really fast to the other side. Keeping your tenodesis just in case. There you go. You can teach it either way. That's fine. And that's when you can hook underneath. Sure. There you go. And you can bring your body forward all the way. Hook this one underneath too. There you go. And you can separate your legs. Now you're in long sitting. There you go. And
And that's for stretching your hamstrings, that's for making sure that you keep your hamstring